Okay. Good afternoon, ladies and gentlemen. My name is Dr. Sayyid Kabir, and I'm a Hepato-Biliary consultant surgeon here. I welcome you all to this webinar that is being hosted live at the Shaukat Khana Memorial Cancer Hospital in Lahore, Pakistan. We all know that the COVID-19 pandemic has played havoc with the healthcare delivery, and in particular with surgery. We have got about over 5 million people infected and over 300,000 deaths worldwide. And as a consequence of this, various national and provincial governments have introduced recommendations to postpone non-essential surgeries. And this has basically been done to preserve personal protective equipment, preserve institutional capacity, and medication and other supplies which may have been needed for treatment of COVID-19 patients. Now, the resultant decline in overall surgical volume has not only delayed surgeries for many patients, but it also has had a financial impact on the healthcare sector. Now, faced with this actual or perceived surge of COVID-19 patients, hospitals across the countries have been contemplating challenges with capacity and patient flow. Now, studies have shown that if you have cancer and you get COVID, your complication rate does go up. And that could be multifactorial because cancer patients are immunocompromised, malnourished, and they have various comorbidities. And as you can see from the graph here, the rate of intubation and the negative consequences of healthcare events are higher if you have cancer and COVID. Now, the exact timing for reopening of elective surgery is unknown. However, hospitals do need to prepare now for when the first wave of this pandemic is behind us. And the best way to do that, prepare for the future, is to learn and share experience with those healthcare clinicians, health leaders, and operation managers who have had experience with providing healthcare during this pandemic. And that is where this webinar comes into play. This is a dynamic 60-minute webinar, and this provides an opportunity to hear the experiences of our expert health faculty who have had experience in providing surgical and oncological services during the COVID-19 pandemic. The webinar aims to provide information that will help physicians improve clinical outcomes by being prepared to resume elective surgery as the COVID-19 surge wanes. So without further ado, let me introduce our fantastic team of speakers. First, we've got Dr. On Raza, who's a consultant in infectious disease and chair of Infection Control Committee in SKM Lahore. We also have Dr. Syed Raza Hussain. He's a consultant in maxillofacial surgery, and he's the head of Department of Surgical Oncology. He's been leading the decision-making processes here at SKM regarding provision of surgical services. We also have Dr. Shahid Khattak, who's a consultant general intestinal surgeon. He's one of our senior surgeons, and he's also very well versed in laparoscopic surgery. And he's been instrumental in formulating the policy for provision of services for the GI oncology. And last but not least, we also have Dr. Asad Parvez, who's a breast oncoplastic surgeon. And his team has been the first one to start doing elective surgery once the pandemic had started to be under more control. So welcome all of you, and thank you for joining us for this webinar. I would like to start with Dr. On first, as he's the part of the team formulating the main response to the COVID pandemic here at Lahore. What has the SKM response been to this COVID-19 pandemic, and what was the rationale behind it?
Thank you, Dr. Irfan, for the introduction and for inviting me here. So, as we all know, that this outbreak of pandemic started from China in December 2019, and soon after that, within a few weeks, it was identified initially as novel coronavirus. So we started preparing our center and our team from January, when we conducted various educational sessions to make our healthcare workers aware about this outbreak and what are the symptoms initially and how it spreads, so that our healthcare workers are aware of this outbreak and pandemic. And the next step was how we will prepare ourselves if we see a patient. So then we planned epidemic drill at the end of January, and then we performed this drill again at the end of February. This was a time when Pakistan, there was first 2 cases were reported in Pakistan.
So fairly early on.
Yeah, 26th of February. Yeah. And then obviously a lot of discussion was going on because we had PPE previously, personal protective equipment at our hospital, but there was a global shortage and regional shortage as well. So we had to think and decide that how can we overcome this shortage by limiting the use of PPE in various areas. So these were the few steps for which we took initially.
That's quite interesting. So very on, you knew there was going to be a problem and you started to deal with that. That's pretty good. So, but what were the main challenges that you faced during this time? Because obviously this is a new thing, and I'll be quite interested to hear your thoughts on that.
So initially, I mean, there were a lot of challenges because, first of all, as I mentioned, this was a new virus. We didn't know much about this virus. We knew about two of its cousins, MERS-CoV and SARS-CoV, but we didn't know about anything about this. So whatever the reports were coming from China initially, and then later on from other parts of the world. So initially there was limited information, but then there was a flood of information. We had to screen and to read through the papers and whether this information is authentic or not, and then what to do next. The next challenge was, I would say that guiding and educating our healthcare workers and addressing their concerns and panic at that time, because they were concerns about shortage of PPE globally. We didn't have the shortage. The problem was that we didn't know whether we will get a supply
in the future.
Not. Yeah, but we had enough numbers of PPE initially, and then preparing guidelines for the rational use of PPE actually. So these were the challenges initially which we faced, and obviously hospital leadership provided resources to overcome all these challenges, and we had the testing capability and facility as well as I think we developed this facility in the month of February, I guess.
So with all this information coming through, I mean, what was your main kind of area which you adhered to in terms of getting that information? And then did you have your team with you, and how did that work?
So we had a team of so me and my other colleague, Dr. Salma. So we were working together. She's also an infectious consultant, and then we had ID fellows and infection control nurses. So we all worked together. So we were following CDC recommendations, WHO recommendations, and IDSA infectious disease.
So fairly authentic sources right there. So what is the policy for PPE for surgical cases at the moment? And I think my colleagues would be quite keen to kind of hear about that.
Yeah, so for our center, we when we started surgeries, and obviously there were concerns about acquiring infection. So we recommended that for all procedures, surgical procedures, we recommended proper PPE, which included sterile gown, sterile gloves, N95 masks, surgical mask on top of N95 mask, because we are reusing N95 mask because of the shortage, and face shield or goggles. So we recommended these PPEs, and obviously we recommended testing 48 to 72 hours prior to procedure of all the surgical patients.
And I think we're going to talk to Dr. Khattab about that in a little bit. But just coming back to the reusability of N95, so and how did you come to that decision, and in terms of usability, how long can it be reused for?
So this is not a new concept actually. So previously, when there was a pandemic, 2009 influenza pandemic, at that time there was a shortage of supplies as well, globally. So so this is not a new idea. So CDC recommends reuse of masks, N95 masks in certain situations when there is a shortage of supply. So, but we at our center, keeping in mind those guidelines, we recommended that we can use N95 masks. So first thing we recommended that we wear a surgical mask over an N95 mask to protect it for visible contamination. And we do not recommend reuse of such N95 mask if it's visibly contaminated or if it's damaged or if it's not making proper seal. So we are not recommending we discard the N95 mask. But if it's clean, then we are recommending that same person obviously will wear this mask for up to 7 days. But if its seal is not proper, its seal is not maintained, then discard the mask.
So safety is important, but we also have to kind of make sure the supply lines remain intact. Right, so that's quite interesting. I would quite like to hear your thoughts on the provision of medical services in the future vis-a-vis the present pandemic, and how do you see this changing?
I think as WHO mentioned as a few days back as well, and personally, we all infectious disease physicians think that this will not go away anytime sooner until vaccine is developed, which will take another year or so. So probably we'll have to live with this, and we'll have to change our practices. The one idea is that which we introduced here as well, and it's introduced all over the world, is telemedicine. So we are doing that, and probably we'll see more clinics that will do more telemedicine clinics. Next thing is that we probably will have to maintain the social distancing thing, even in hospitals, and judicious use of PPEs as well, and proper adhering to basic infection control practices like hand hygiene and basic standard precautions. We will have to, adhere with these practices and standards, and we'll have to live with it, and this will definitely affect our lives, but that's how it is.
Okay. Okay, so thank you very much, Dr. On, for that insight. I think I'm going to direct my question next to Dr. Raza, who's also our head of department and maxillofacial surgeon. Dr. Raza, thank you very much for joining us here. What were the unique risks that head and neck surgery is associated with in terms of pandemic?
So thank you very much, Dr. Irfan, for arranging this very important and pertinent webinar, especially coming from a cancer hospital. Because as we all know, we had to, for some time, let go of our elective surgery. So I'm not going to discuss, in the interest of time, the dental emergencies and the orofacial trauma fractures, because obviously they are, if they are life-threatening, they had to be done with, as Dr. Onrada mentioned, proper PPEs and with standard precautions. Apart from that, we come across advanced cancer cases in oral cavity, nasopharynx, and as you know, these are the regions where there is a high viral load, and we had to be very careful in dealing with those life-threatening emergencies. So initially, all elective work when it comes to head and neck cancer was postponed or delayed, and we all know that 2 or 3 weeks of these can be delayed, especially if they're early stage cancers. When it comes to airway, either coming from ICU or elective, it was only for those who required an urgent or absolute necessary tracheostomies, and we prefer to do an open one rather than percutaneous one in ICU. So again, taking all the necessary precautions and with all the precautions at the OR, keeping minimal staff in OR, done by the senior most skilled specialist or consultant, so that you minimize the risk of complications and keep the operating time as minimum as possible. So essentially, aerosol generating procedures were delayed or postponed or stopped for a couple of weeks. And as the evidence poured in from all over the world, in a way we were lucky that we were getting people were sharing their experiences, especially in head and neck. So we were we were improving as on a daily basis, weekly basis. So essentially, the airway management was restricted for only the life-threatening procedures. Okay. I mean, as a life-threatening procedure.
Okay. So in terms of airway management, if somebody needs a life-threatening injury and needs a tracheostomy, then you would do it. Otherwise,
yeah, of course. I mean, if it's an ICU case with a prolonged intubation, then yes, you have to see the pros and cons and weigh the risks, benefits. Otherwise, with the precautions that Dr. On just mentioned, we can carry on with an open tracheostomy.
So you mentioned there again delaying cancer cases and so forth, which will be appropriate to kind of delay. What were the guidelines that kind of help you decide on which patients to delay and which ones not? Like, is there any brief papers out there that you can talk about?
a very good paper that came in March, and then there are a few from in April published regarding head and neck cancer. And everyone was aware of the fact that the mucosal cancers carried the highest risk of to the healthcare worker, as well as if you operate on them so they were the ones who were postponed. So if in a cancer setting like ours, we have the luxury of having the oncologist on board, and so every case was discussed, and like any other case in an MDTs, and for those who could be given induction chemo or neoadjuvant, or to buy some time, they were offered that. The other option was to just keep an eye on them for a few weeks and then reassess them. And like we have restarted the surgery, because we hardly stopped for 2 to 3 weeks. So we were back in the OR, treating these cases. So I think it was all calculated and a case-to-case basis decision making to make sure that the patients didn't progress in their disease, and making their outcome poor. So we were quite lucky that our chemotherapy and radiotherapy services were continuing, even though the surgical services were stopped for a couple of weeks.
Just to let my viewers know, I'm just sharing the 2 papers that Dr. Raza has just talked about. It's the evidence-based guidelines for the management of head and neck and mucosal malignancies that's just been published recently and updated, and similarly the brief guidelines for the prevention of COVID-19 infection in head and neck and otolaryngology surgeons. So that's something out there if you guys want to take a look at that. Now, coming back to Dr. Raza, I'm going to talk about the SKM experience of restarting head and neck surgery. How has that been for you and your personal experiences in that?
Like I mentioned earlier, we were quite lucky that we were getting evidence from from China, from US, from EU countries, and of course with the help of our ID colleagues, we were able to restart. And again, we started off with non-mucosal cases like major salivary gland resections, thyroid, and so. Of course, with all the standard PPEs, and of course doing their pre-op COVID test 48 hours before. So we and the other thing that we are all experiencing, and I'm sure the rest of the world is also experiencing, is the turnover time and the operating time has slightly increased, because it's not that easy to operate with all these protective gear. So that's something that. As Dr. Ron mentioned, that because we will have to live with it for a longer period of time, the sooner we get used to it, the better. So that and as head and neck volume is so high that we need to slowly and surely get back to our normal routine, what it was before this pandemic. So we have started, and we have, of course, we have started with shorter duration procedures, taking 2 to 3 hours, and procedure which require major complex resection as well as reconstruction or free flap reconstruction. I think we will be starting that from the next week, but I think for the time being, a local flap or a pedicle flap with a resection and a neck dissection, which takes about 2 to 3 hours maximum, is the one that we have started. And realistically, we should be doing these surgeries incrementally, so that it's not that easy to do a very long procedure under these current circumstances.
I'm just going to bring you back to that, because that's a very pertinent thing that you mentioned of long operations with using all the protective gear. So do you have any strategies that you could share with our viewers regarding how to cope with using an N95 mask and all those other PPEs that we kind of use for surgery, and how can we make things better?
Yeah, so we're using, some people prefer goggles. I prefer a shield. So it all depends. The only thing is, if you are wearing operating loops, then it becomes very difficult to wear all these. But otherwise, what we are doing is that every procedure is a consultant-led procedure. It shortens the time, and so. If you want a break in between, you can go, but I think I prefer to, do everything in one go and then take a break as soon as you're done. But realistically, I think there is no shortcuts in a procedure like this where you have to do a resection, a neck dissection, and a small local flap or something. So I think you just have to start, and once you do a few procedures, you get used to it, and hopefully, inshallah, it will not be an issue for all of my colleagues in the country.
One last question, and that is, how did you manage to kind of get a balance between that need to provide training to your fellows, like you said, and the need to protect them by doing the procedures yourself and kind of making sure they get done appropriately and quickly enough, because obviously it has consequences for the patients as well as the staff in theaters.
So right now, I think we are too early to be worrying about the trainees or the fellows training, and their. I think there's a few months of this delay is not going to affect their overall training in the long run. I think in the best interest of my team and of course the patient, we should at the moment do the whole procedure if you can, and inshallah slowly and gradually. Once we get more comfortable, we get used to this, then yes, you can let the trainee or your fellow do half or some part of the procedure and take a break.
Plus, I suppose they get to see the master at work as well, so there's always learning there.
Yeah, I mean, I'm quite lucky that I have a very experienced and senior fellow. But right now, I think it's best that as the consultant or the lead surgeon, you should try to be the main operator rather than relying on your assistants.
And your thoughts on the future?
Like On said, I think this is going to stay, and we need to be, we need to think long term, and we need to restart now. I think we know we have enough evidence, and with proper care and proper protection, I think we can go a long way. But we will not be able to do the same numbers that we were doing before, because I think there's a lot that has changed in your OR setting, and the overall stress on cleaning and cross-infection care and all those things. So I think we need to keep that in mind, that we probably will not be doing the same numbers as we were before.
Because the turnover time.
Yeah, turnover time has increased.
Okay. Thank you very much, Dr. Raza. I think your experience in the management of veterinary cancers have been invaluable. Now, to share his expert experience on how to manage patients with gastrointestinal cancers during this pandemic, I welcome Dr. Shahid Khattak. Thank you very much for joining us.
Thank you very much, Irfan.
Dr. Khattak, what sort of planning did you guys undertake when the first signs of the COVID-19 disease started to come across?
Well, I'll just second Dr. On, our ID colleague, that when we saw it coming to our side, we were slightly lucky that we were a bit late. We were not like China and Italy, so we got some time, and our hospital management decided to help the government and the public sector that they will take COVID patient, and it was decided that the surgical floor will be used for the COVID patients, and at some stage we have to cancel the elective surgeries. We started with the pre-COVID phase, when that was the time when we were providing the testing facility, but we didn't have any COVID patient on our side, and we were advised by the management to do as many GI cancer patients as possible before we actually stopped doing elective surgery. That phase lasted for about, say, week to 10 days, and we tried to do as many as possible. Then the second phase was a shorter phase, but that was the most difficult phase, where we actually stopped all the elective work, and we were left with only 2 operating theaters, one for COVID patient and one for non-COVID patients.
Right.
We continued with our MDTs and discussed all the management of cases, but at that stage, as we were not doing the elective surgery, as you know, in GI oncological surgery, there are 3 types of surgery, I would say. One are the emergency surgeries, which are the perforations and the obstructions, and one are the urgent surgeries, where the MDT decide that these patients should have an upfront surgery. Most of them in this country are chronic neoplasms. And the third one are the patients who first need a neoadjuvant treatment, followed by the surgery. So we had all these three groups of patients. In the first phase, we did all three of them. But in the next phase, where we were doing only emergencies, so we only stuck to the patient who were either perforated or obstructed. At that stage, we were screening all patients for the symptoms, but we were testing only the symptomatics, and we were provided PPEs for including N95 for all surgeries. During this difficult time, we had numerous multidisciplinary meetings with hospital management, with ID colleagues, with oncologists, and we were planning for the next step. We couldn't stop the elective surgery for too long because it's a cancer hospital, and we had to do it. So we planned for the next phase, which was the phase 2. In phase 2, we increased our OR capacity from 2 to 4, and then took it to 6 in the next couple of weeks. And we decided that we will start with surgeries which are mostly day cases, or which takes about 24 to 48 hours. Right. Unfortunately, in my specialty, there are not that many resections which can fit into that. So we had to wait. But the breast surgeons and the head and neck, as I mentioned, and orthopedic surgeons, they did quite a lot of cases during that phase. In that phase, we did, again, a screening of all patients, and we, as the testing capabilities were limited, as far as the kids were concerned, we were testing the symptomatic ones, but the PPEs were, including N95, was available to all. Then we decided to go to the next phase, and we increased the OR list near to the maximum. Okay. And that's where we started the elective GI surgery for most of the patients who have been waiting after their neoadjuvant. Let me add, in this period when we were discussing with the oncologist, what we did, for example, the patients who were ready for their resections after the neoadjuvant treatment, we actually spoke to our oncologist and gave them further chemotherapy, so that they don't have to be without any treatment for the duration, because the operation has to be delayed.
And was this the time period where we didn't have the full capacity for theaters to operate?
That was the phase, which I call it phase 1, where we were not doing any elective work. We were just doing the emergency surgeries, and obviously some part of phase 2 where we're doing breast surgeries, but not really elective resections for post-neoadjuvant treatment. So we give them another cycle of chemo in most of the cases. In phase 3, the good thing is we got our ICU and HDU back, and we got most of our theaters back. We got a lot of beds, which were initially given to the COVID side, and we had discussion with the management, and at this stage we had now the testing capabilities, the on-site testing capabilities were improved. So now we decided that all elective surgeries, all patients who need surgery will be not only screened, but they will be tested as well within 48 hours prior to surgery. And in addition to that, we used PPEs, including N95, as mentioned by On. And we are hoping now for the next phase, which is going to be after Eid. Hopefully, if the epidemic didn't get worse in this country, we are hoping that we will go to our full throttle after Eid break. All OR will be open, and we'll start our esophageal surgery back as well, because I think that's the only one which we haven't done. The rest, we have done our colonic, gastric, and rectal resections already.
So on that note, I'm just going to ask a question here. So do you think it is actually safe now to restart your surgical procedures? And if you think that, why do you think that?
Well, I mean, safety is a very relative term, you know. On one side, if you think nothing can be safe, you know, at this moment, but I'm glad that, you know, the world has taken this, and there are numerous people who have written about it. I specifically mentioned, I think these are on the slide, you know, the two guidelines, you know, for resuming elective surgery. One is from the American College of Surgeons and the Association of Anesthetists in the US, and the other is from the Association of Coloproctologists in Great Britain. They have published their guidelines. I think it is they've actually, it is 17th of May. Initial was in April, but now they have updated it on just a couple of days back. We go to the next slide. Yeah, I mean, in the Association of Coloproctology, we have actually taken these guidelines mostly. And if you look at it, they say that vulnerability of individual patients. One are the patients who probably will have a small operations, you know, and their morbidity and mortality won't be increased if they have a COVID-19 infection. Our GI patients are mostly in the V2 category, where if they have a COVID infection, that can really increase their mortality and morbidity, because, as you know, most of the GI cancers are where you either open the abdomen, or sometimes in the esophagectomies you open also the thoracic cavity. So post-operative respiratory complications are quite common. So if the patient also have got a COVID infection, that can really increase your morbidity and mortality. So our GI patients will, I would say, fall in this group. And they've also spoken about the hospital, what type of facilities you have. The E1 facilities are the core facilities, which are almost completely free of COVID-19, while E2 are where there are segregated services on the same site with almost COVID-free cold facility designed solely for elective surgery. Our hospital will actually fit into the E2 category. And the recommendation by both these associations is that you should have either E1 or E2 environmental facilities before you start thinking of elective surgery. So as we fit into this E2 facility, we decided that we have enough beds, we have enough space in the enough separate ICU, I would say.
So you have a separate ICU.
We have now. We have a separate ICU where we can take our patients. For example, if I do an anterior section and unfortunately if it leaks and I have to go back, and if we need ventilation or if we need HDU facilities, we have a space where which is COVID-free. It is not shared by any corona patients, where he can go, or if they have a collection or something and they need an intervention radiology input for drainage, we have those facilities. We have started our endoscopy suite is also working. So if I need some help from our gastroenterologist, I have that facility. I will say that we are, from that side, we are near to, as far as the backup facilities is concerned, blood bank, pathology, we have all the backup back now,
which is important
before we can start elective surgery. And I will actually advise to my colleagues up and down the country and anywhere in the world who are listening that if you go through these guidelines, it will help you before you can start your elective surgeries.
Just very briefly, I'm just going to ask a question, which is maybe slightly off-putting. There's a lot of been talk about laparoscopic versus open surgery.
Yeah.
Can you just give us your thoughts on the topic very briefly?
Well, I think initially when I will say that things change so quickly now. A month ago, there were a lot of publications, saying, and they were talking about the use of use of diathermy and ultrasonic devices,
yes.
The fumes from there, which can be concentrated in the abdomen, and if you have got a leak from a valve or something, viral can be transmitted. So we also, at that stage, when we were doing the emergency surgeries only, we were not doing any laparoscopy. We were doing mostly open. But I mean, I will say that at this stage, laparoscopic surgery has been there for 30 years.
Yes.
And it took I mean, there's so many advantages to it. So overnight, all these advantages are not going to go away.
No, they aren't.
So you have to look at, your individual patient, that how much benefit are you going to get from laparoscopic surgery? And you have to take, change your practice a bit about the trocars, about the use of suction devices, and use of how you use your electro coagulation and you have to make sure that if you are to convert it into open, or maximum when you are actually removing the specimen, that you remove all the pneumoperitoneum, all the air out before you open it to reduce the viral.
Okay, that's good to hear. So laparoscopy surgery is not out at the moment. That's good to know.
Not in our unit.
Not in our unit, at least, yes. So just going to move on because of time. How have you managed to keep a balance between keeping up the morale of your patients and of your trainees? Because obviously these are difficult times for the patients as well as the trainees, and there's a lot of misinformation out there as well. So how did you manage to find a balance with all this?
Well, let's say that when we actually stopped our elective surgery, just only for a couple of weeks, from the we regularly got in touch with our patients. I will say that one good thing which came out of all this COVID is teleclinics. So we did a lot of teleclinics. We spoke to our patient on the phone. We just explained to them the pros and cons, of delaying the operation or doing it in the epidemic. We took them in the decision making, and I think it is extremely important that they don't feel that they are left out, in these difficult times. The same goes to the trainees. Surgical trainees love to be in OR.
True.
And obviously, in this difficult time, there were not that many ORs open that they can work in. So what we did, that we utilized most of the time in research, which is also an important component of their training. We organized small meetings, help them with the database and with the research topics, because we had more time as well, because the operation theater was closed, so we had more time. And I will again say that one good thing might be that I'm hoping that this year the surgical department will have the maximum research publications out of this time when we were not operating.
Opportunity in this situation.
And we thank COVID for that.
Yes. Looking forward to some very good publications from the department. Okay. So finally, very briefly, your personal thoughts on the future.
Well, I think On is an expert, as he has mentioned, and looking at the media, and that this thing is not going to go away that soon. And I think we have to live with it for some time. We have to change our ways inside the hospital and outside the hospital, the way we were using our time at home, at shopping malls, and within the hospital. And as Reza has mentioned, the number of patients which we were able to do on one elective list, I don't think so we will be able to do the same numbers for quite some time, because the changeover times, the cleaning, all is time consuming.
That's good to know, sir. That was very informative, Dr. Khalid. Thank you very much. I'm going to turn my attention to Dr. Asad now, and I'm very keen to learn from his experience in starting or being the first team to start elective breast surgery during this pandemic. Dr. Asad, thank you very much for joining us. How has the COVID-19, this will be just a general question like the start, how has it affected breast cancer services, and how has your guidelines been modified?
Sure. Breast cancer remains the commonest cancer that affects people worldwide. According to one study in Pakistan, there are about 90,000 women and men who suffer with breast cancer every year. And about half of them, unfortunately, die every year. About 40,000 people die every year. Here at SKM, we treat about 1,500 breast cancer patients, new breast cancer patients, on annual basis, which means every week between my colleagues and myself, we operate about 40 to 50 patients for breast cancer. And this was pre-COVID era. And when this came, then we all, as you mentioned, we all stopped operating. This happened towards the end of March. And there were like 2.5 weeks when no elective surgery was performed. Mm-hmm. And as you would know, that majority of breast cancer patients, they are operated after neoadjuvant chemotherapy. Mm-hmm. In fact, about 2/3 of our patients, they have neoadjuvant chemotherapy, and then they have a strict timeline that they should be operated within 3 to 4 weeks after the end of chemotherapy.
Right.
And by not operating for 2.5 weeks, we had the backlog of about 100 patients that they should have been operated during that time when there was no single operation was done.
That's a big number.
Big number. So when the management and ID team allowed us to start operating, which was week beginning 13th of April, we already had that backlog of about 100 patients, and then this backlog was accumulating. The Shaukat Khanum Hospital stopped taking new cancer patients during that time, briefly. However, we had that backlog of patients who were finishing chemotherapy and they were due for their surgery. Mm-hmm. So initially, we started very cautiously with all the PPEs. We were operating on daily basis, taking turns between colleagues, and we were operating on 3 patients only every day. So first week, we operated on 15 patients. The second week, we increased the capacity and jumped to 30 patients a week. To this week, where we are operating on around 60 patients.
60 patients. That's an impressive number.
Thank you. And overall, during these 6 weeks since we started working, we have operated on over 160 patients during those 6 weeks, which averages to around 28 per week, which is still behind or below our average number of 40 to 50. But we have learned that this is going to be future. We have to be very cautious with all the PPEs and preparations. But if we do not offer treatment, if we do not offer surgical treatment in timely fashion, the problem is that the disease, the cancer will progress, and that will affect the patient. So we have to offer.
And first of all, congratulations on doing such a huge number. But then the question arises, how do you prevent burnout within your team? Because you have to use PPEs, there's a lot of patients coming in, there's a lot of stress from the COVID. So how do you prevent that burnout within your team?
We devise strategies amongst the colleagues and different tiers of surgeons as well as nursing staff, that not everyone was present in the operating room every day. Mm-hmm. So we developed rotas between colleagues. We were taking turns. Initially, we were operating like alternate days, but then the time came when one of us was operating every day during the week, and the other one was taking the week off or doing the clinics. So we had this strategy of taking time off from operating, and we also gave time to fellows, to our junior colleagues, to our resident doctors, medical officers, as well as the nursing staff and the operating room assistants who would take turns to prevent the burnout. The other thing was that we also modified how we were dealing with the patients as well. Majority of our patients were admitted before COVID times. But with this, we worked on, we thought that we should be expanding our day case surgery and short stay surgeries. So we amongst all these operations that I have mentioned, about 66%, 2/3 of them, they were day cases. They were discharged home. The cutoff was 8 p.m. that they should go home before 8 o'clock in the evening. There were very strict monitoring about about how, and from the timing point of view, that how and when their operation finished and how much time they spent in the recovery and when did they actually discharge from the hospital.
So what you're saying is, from this COVID pandemic, we've kind of realized short stay surgery is possible in breast surgery.
It is. It was just something that we were doing before as well, but for very limited number of patients.
Right.
But with this COVID, we expanded the number in selected patients that we could offer day cases. And even in the admissions, they were all short stay admissions.
Right.
Even the biggest operation, they were discharged within 24 hours the next.
So what was your strategy for reducing this, i.e. use of you already mentioned the daycare surgery in teleclinics. Was it easy to establish all these things?
I have to admit, no, it wasn't easy. It was difficult, challenging, and to begin with, it was very scary as well, that majority of us did not know the natural course of the disease.
Right.
Every day the information was changing. But the most important thing that was helpful was information.
Right.
From the colleagues, from our ID team, infectious disease department, from within our surgical oncology department, that we were communicating with each other. We had daily emails from ID team and support from the hospital management. That we were updated on daily basis, that what were the PPE requirements, for example, what were the patient requirements, how could we monitor the patient better, how could we decide which patients should be operated on, and which patients could be delayed, could be postponed. And during this time, as per hospital management and ID team, we started doing the testing for COVID as well, which helped in knowing which patients were positive and their surgeries could be postponed.
Okay. Well, Dr. Asad, thank you very much for your experience from the front line. Definitely helped us understand the logistical issues associated with providing short stay surgical care as well in this unprecedented times. I'm briefly going to talk about some hepatobiliary stuff and then we'll move to the question and answer session. So hepatobiliary had various recommendations done from different societies. And there's been kind of major issues with hepatobiliary surgery, as most of our surgeries are quite long. They're about 6 to 8 hours. And the operations are quite complicated and complex with high risks of bleeding and so forth. So you're faced with these long surgeries where there's a lot of fatigue, and especially with PPEs, as mentioned by Dr. Raza and my other colleagues, it's very difficult to kind of stay focused for that period of time. So our strategies basically was to kind of divide the teams into two, and we're kind of working on that. We've just started hepatobiliary, one of the recent specialties to restart surgeries. And we're going to try and kind of cope by having two teams which can do half of the operation at one point, and then the other team comes in, and that's going to break up the time so that the fatigue is reduced. The guidelines for preoperative testing remains the same as the other specialities, and it's the same as making sure the patient is asymptomatic and they've got the testing done 48 hours before. There's been a lot of talk about use of CT scan in the preoperative setting for hepatobiliary patients, and all the recent studies and kind of data suggest that there's absolutely no role for that unless there are other reasons for doing the CT scan. Now, brief guidelines for pancreatic cancer: if it is an upfront resectable cancer and the services are available, then you should go ahead and do the surgery. If not, then neoadjuvant chemotherapy can be used as a bridging if the resources are limited. And that's the route we took when the COVID pandemic was started and we had to reduce our surgical services. And however, as time has gone by, we can start changing that practice again. For borderline resectable cancers, obviously we're going to go down the neoadjuvant chemotherapy route as used to happen in the pre-pandemic days. If, however, the patient has completed the neoadjuvant chemotherapy and they are ready for surgery and they're still resectable, because the resources are a bit limited at the moment, we are kind of speaking to our oncologists and we're kind of pushing for 2 or 3 more cycles of chemotherapy if the patient can tolerate it. If, however, the patient can't tolerate the chemotherapy, and then we have to kind of bite the bullet and do the surgery with all the necessary precautions. However, in case of pre-malignant lesions like neuroendocrine tumors and gastrointestinal stromal tumors, we are not doing any surgery for that at the moment, because these patients do not have any risk to their life in the immediate future, and they can all wait till this pandemic has evolved and our resources have become better. Now, similarly for liver cancers, for hepatocellular carcinoma, if the resources are limited, we are going down the TACE or ablation route. If they're fit and they're young and they would benefit more from surgery, and if the resources are available, and that's something which could be offered, but they have to be quite fit and young patients for that. Similarly for colorectal metastasis, if they're small, we're not going down the surgical route at this stage, we're going down the ablation route, because we do know that in the short term the results are almost similar. So the ablation acts as a bridge to surgery. However, if that's not possible, then we are considering chemotherapy to kind of tide over the time. However, cholangiocarcinomas, that's a very different ball game. Again, it carries very high morbidity, very high mortality. So unless until the patient is very fit and it is clearly resectable on the imaging, we are not going down the surgical route, and we're going to go down the non-surgical routes for that. Now, that was very briefly, I was going to talk about hepatocellular carcinoma and so forth. And with that, we come to the end of our kind of discussion. And I'm just going to see if there's been any questions that have been kind of put forward to us by anybody. And there's quite a few questions that have come to us. I'm going to briefly talk about this. The gentleman who's asked about the pre-op COVID testing. Where should we keep the patient until the results of the test becomes available, or elsewhere? So this question I'm going to direct to Dr. Raza. He's our infection control lead on this, so he can talk more about this.
Yeah, so I think as Dr. Asif asked, I think these patients should be kept in isolation because we are suspecting that they have a COVID infection, although it's asymptomatic. So they should be kept separate in isolation, and during that 48 hours time, because even if the result is negative, they should be isolated. They should isolate themselves so that they are not exposed to anyone who has asymptomatic COVID and then they acquire COVID, and before surgery they acquire COVID infection, because that can lead to poor outcome of the surgery as well. So they should be isolated.
Okay, so I think there's another question similar to that from anonymous who says whether the patient should be kept in isolation, and I think you just answered that question anyway. I'm going to.
Can I just add, I mean, it all depends what sort of a patient population we're dealing with. So at SKM, most of our patients are not from Lahore. So, it's very difficult to either bring them in 2 or 3 days before, because obviously we don't have enough beds for all of these patients in hospital. So essentially it's a counseling which needs proper counseling, so that they should not go back into the community. They should be made aware, why are we doing this test before surgery? And so self-isolation, whether at home or wherever they're staying, if not in the hospital. But I know it's very difficult to make sure that the patient is following the instructions, especially if it's not in the hospital.
Okay, so a question again. Should they go for soft tissue procedures and postpone bony procedures in head and neck? That's the question I'm going to pass on to Dr. Raza.
Yeah. So I think the gentleman wants to know about bony procedures, whether it's resection or fractures. I think if there's a fracture which cannot be delayed, most of them can't be. So you have to deal with them with whatever reduction fixation techniques you follow, with all the necessary precautions. Apart from PPEs, you should have high-speed suction, proper OR ventilation, and carry on with either, resection or fixation with screws and plates. Okay.
Another question regarding the specific type of PPEs to be used for head and neck cancer. So I'll leave it up to Dr. On and Dr. Raza to answer that one.
Yeah, I mean, they're standard for yes, head and neck. Probably if you compare that with I don't know, orthopedics or some small skin excision, yes, the risk is more because you're either working in oral cavity or sinonasal area. So it's the goggle or a shield, N95 respirators, or the other mask. We normally wear another surgical mask so that we can reuse N95. But again, if your N95 becomes soiled or gets contaminated, or you can't use it the next day or for the next patient, then yes, you should replace your N95 and impermeable or a waterproof gown. And they are usually single-use disposable ones, so you can't use your the ones we normally use in re-sterilizable cotton or fabric gowns, not anymore. So, but these precautions or these PPEs are for all specialties, not just for head and neck.
So, Dr. Nazir, I hope that has answered the question. I'm just going to ask a question from Dr. Khattak in terms of how does is there any difference between esophageal surgery and colorectal surgery when it comes to this pandemic? And do you see any difference in terms of use of PPEs and patient selection, or?
Not necessarily in the use of PPEs, but obviously patient selection. Yes. Esophageal cancers, we have in this country, as compared to the West, we get quite a lot of squamous cell carcinomas. And for the squamous cell carcinomas, the usual recommendation is either trimodality or bimodality treatments. Most of our patients do get chemoradiation first before we operate. So that gave us a good window period that we have to wait until their radiation works before we can take them for surgery. So we do get geojunctional tumors, which are mostly adenocarcinoma, which you have to do as compared to squamous. But with squamous, the benefit we had during this period that we were not that much pushed to do them in time. I mean, we had more lag period for them, and hopefully once we started them during the next week, I am hoping that most of them, when we rescan them and restage them, the disease wouldn't have progressed. Rectal cancer is slightly different. Nowadays, you scan them at 4 weeks after neoadjuvant. If the disease has shown progress, then you can leave it up to 12 weeks and do it at about 12 weeks. But if it has not responded to the neoadjuvant, then you need to do them sooner. So in other words, I would say we are more pushed to do the rectums in time as compared to the esophagus.
It's good to hear that. So Dr. I've got another question for you here from a gentleman called Nurul Mubin. He's asked whether needle pricks can also transmit the infection.
Well, at this point, there is no documented evidence that it can be transmitted from this, but
who knows?
Yeah,
We don't know.
At this point, it's not.
So Dr. Mubin, watch this space. I've got a question regarding the use of loops with shields.
Yeah, so I think the off-the-shelf loops are quite, what's the word? The dimension is such that, it's probably not possible to wear a goggle over it or a shield over it. So probably you will have to modify it. If you wear loops for all your surgeries, then you will have to have a loop which has a broader base, so that that can act as a goggle rather than wearing another shield over it. Luckily, I don't wear loops for my procedures. If I have to, then we use goggle with my operating microscope. But I can understand it's not going to be that easy to wear the loop underneath a shield. The best is to probably invest in better loops.
Mm-hmm. So there you go. A lot of money coming out of your pocket. Right. So there's another question here regarding robotic surgery. I'm probably not going to answer that question because it's not really pertinent to us. We don't have much experience with robotic, but we don't have.
I think the person who is asking this question is probably because robotic surgery, the person is actually not on
sitting
the table
yes.
operating. So I can see why it is coming up, that there will be less chance of touching each other or getting closer to each other. So there will be less chance. But even in the robotic surgery, the main surgeon is sitting, aside, but there are other nursing staff who are around the table. I have to say, that if you look at that, then probably the open surgery, people are, and everybody has to look at that abdomen, so everybody is closer to each other. In laparoscopic surgery, there's a bit more distance, while in robotic surgery, obviously there's more distance between each other. So theoretically, there might be less chance of contaminating each other. But it will be all theoretical.
So one last question before we call it a day. So it says, how long will strict measures will have to be taken to go before things go back to the past normal? Now I could take if everything's okay with that, I can take that question. And I don't think we are going to go back to the normal. I think what the future holds is unknown. We don't know what the future holds and how things will be, but one thing is for sure, it's not going to be the same as it was before. So the answer to that is probably we're never going to go back to the norm.
I think we need to get used to the new normal.
We need to get used to the new normal.
We need to concentrate on staying alive.
Yes.
And keeping people alive rather than
yes, I think that's
to the old normal.
Dr. Asad has said it very nicely. We need to get used to the new normal and just carry on with things and just move on. So with that, I think we're running out of time. I'm just going to make some few closing remarks. We're yet to see how the world changes and when this pandemic wanes. But what is certain, like Dr. Asad said, is this is the new, we're going to have to get used to a new normal. Surgical care will definitely see changes as more remote monitoring, teleclinics, increased time frame for surveillance, and less at-risk surgeries being undertaken. And that's going to be interesting how this evolves. We are coming to the end of this webinar, and I hope this has been as valuable for you all who are watching as it has been for me. I would like to thank all my speakers today, Dr. On, Dr. Raza, Dr. Asad, Dr. Hattak, for giving us their valuable time and for sharing their experience with us. Please do let us know your thoughts and feedback on this webinar. With that, I take my leave. Thank you and good night. Thank you very much.
Thank you.
Thank you.